Well, good evening, everyone, and welcome to the May meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter with Dr. Amy Cipolla, who is here as well and who is at the controls tonight and is going to be overseeing the meeting. And I'm going to give the floor over to Amy in just a moment to introduce our speaker and topic. I just had a couple of really quick things to say. The first one is that tonight's episode continues our strategy of venturing into areas, topics, fields that we have not done before. And this presentation certainly fits that bill because we have never done anything on integrative pharmacology, even though Amy is an integrative pharmacologist, but we haven't gone into that field in terms of webinars before. So I just want to mention that, and she's going to introduce in a moment. And two other quick announcements. If you would like to join our mailing list and receive the chapter's more or less monthly newsletter with, upcoming schedule of events and other announcements, there's a link in the chat that Amy just put in that you can click on. And I have to say something very important about this link. I just discovered yesterday or the day before that we have many people who have subscribed who actually are not receiving our information because there's really a two-step process. You have to click onto the link and then you fill in a couple of really quick fields that take you 30 seconds or less. And then you hit submit. But that's not the end of the process. You're going to get a confirmation email from our platform. And it's not enough to just get the confirmation email. You actually have to confirm. You have to open up the email and hit confirm. And that's what the problem has been previously. And so I just want to make that really clear that if you do want to join, you've got to hit the confirmation. And finally, I just wanted to announce that our June event coming up on June 10th is going to be a little switch from our usual. It's not going to be a webinar. Every once in a while, we do an in-person networking event, social event. And so if you are anywhere in the Cleveland vicinity or actually metro Cleveland vicinity, and you are interested in meeting some of your fellow IM community members, please come and join us on June 10th. And there'll be an upcoming announcement in the next newsletter about the details of that. But it's June 10th. It's going to be from 6 to 8 p.m. I think that's a Wednesday as well. And it's going to be in the office of Dr. Lily White, who was actually our first co-leader back 6 years ago. And it's in Rocky River, Ohio. So with that, I'm going to hand it over to you, Amy.
All right, thanks, Peter. So as Peter said, I put the link in the chat to sign up for our newsletter. And if you ever have questions, you can ask Peter or I as well. I am incredibly grateful to have Dr. Emla Thibault here today to present on how integrating nutrient and biomarker testing into clinical practice can transform patient interactions. She is an alumni of Ohio State University, which is especially close to my heart because I went there as well and love Ohio State. So we were just so lucky to have her with us here tonight. We shared her bio, so I won't reread that, but definitely I would read her bio, visit her website. And again, we're just so grateful to have you here. So I'll hand over the floor. And as a reminder, if you have questions tonight, go ahead and put them in the Q&A. And then we can hopefully take some questions at the end as well.
Well, thank you, Amy. Thank you, Peter. I really appreciate everybody. Thank you for having me today. I'm honored and excited to be here. I hope there's some Buckeye fans in here or some Ohio State. OH, am I alone saying that? Is it just Amy and I? Thank you. I love that. Dang it, I just saw something in the chat. I'm not happy about that. But I'm so honored to be here today. I'm going to share my screen. Can you see my screen, Amy?
Yes.
All right, lovely. So a little bit about myself. If you can't tell from the accent, I originally am from Cameroon, West Africa, or Central Africa, depending on how you look at it. But and Cameroon is a British/French colony. And so about 80% French speaking, 20% English speaking, and over 200 different dialects. So several different tribes. And it's as developing of a country as it gets. And in my childhood, typhoid, dysentery, cholera, you name it. The infectious diseases where it's a common thing. And I've had malaria over 30, 40, 50 times. And I say this not to, make you think that, like if I'm like, oh, she's amazing. She's had malaria 30 times or 40 times and she's fine. If you were to discuss with anybody who grew up in West Central African region, they would tell you a similar story, if not worse. So typhoid fever and malaria are commonplace. So initially going to school, I did my undergrad back home, and then the normal thing is that people hope to travel to a developed country, where there's no infectious disease, where there are better opportunities for education, for higher education opportunities. And so that's how I found myself in the US. And so I was doing a master's in molecular genetics in Chicago. And I was thinking that, oh, right, infectious diseases all the way behind me. And I am here in America and I'm about to live the American dream. So lived in Chicago, did that master's for a little bit, worked a little bit, and then enrolled in the Doctor of Pharmacy program at Ohio State, where I worked with Generation RX. And it just became increasingly clear to me that I just changed the type of problem. It was no longer infectious disease, which was the problem. It was now chronic disease. So I was immersed in a society where people, I kept thinking to myself that, I kind of wish chronic diseases hurt a little bit more. Like if, when your blood sugar started rising, it was painful. And so we would be a little bit more attuned to it. And just with blood pressure, you just sit. But the thing with malaria, if a mosquito bites you and you have malaria, within a few days, you feel really bad. You feel really horrible. You kind of have to do something about it. So it's easier to get to it. But with chronic diseases, it has been really. I'm trying to move the chat to one side. Yeah, with chronic disease, it's different. It's different because we sit and we can be unawares, as you guys are very cognizant of that fact. So I finished my Doctor of Pharmacy studies at OSU. I worked with Kroger. I worked with Children's Hospital for a little bit, but the craving to be able to practice pharmacy just the way I experienced it back home and just a little different, the way I imagined it in my head is what pulled me to open Power Pharmacy. And in this country, we have done a fantastic job of treatment and guidelines and all the advances in modern medicine, but we have left behind the other pillars of lifestyle medicine, which we have not mentioned, we have not talked about, and it's really not highlighted. Nutrition, movement, inner alignment, positive social connection, all the other pillars that we don't bring to the forefront. And we spend 90%. We mention those, but we don't highlight them. And we don't give patients the tools to be able to make those actionable and sustainable, especially in the practice of pharmacy. I think it's across the board in the practice for healthcare practices across the board. But in pharmacy practice, we have this strong polarity, which, I am for GLP-1s. I am not for GLP-1s. Or I am giving vaccines. I am not giving vaccines. There's always something. Or I'm for statins. I am not for statins. So we are in these separate camps. And the people in my camp, we don't like you in your camp. And we just think that you don't get it quite right because we think that we're correct. And you in that camp, yeah, you need to study. You need to come learn our way so you can do it the right way like us. And that's what I notice when I talk with healthcare providers, pharmacists around around here now, and I'm thinking, this is not helping us. This is not serving us. I've never met somebody who wants to jeopardize their health. I've never met a patient who wakes up in the morning and goes, I'm coming to the pharmacy so I can get some metformin. Very excited to come get some metformin, or very excited to come get some probiotic, or this is, it's on their shopping list. Nobody has metformin or statin on their shopping list. What they have on their shopping list at the back of their minds is optimal health. So they're passing by the pharmacy, hoping that they'll get something from me. Or when they come to you and you write a prescription, the goal is not to get that prescription. The goal is to get what the prescription is going to give them. The goal is for them to be able to say, you know what? I want optimal health. I want to lead a fulfilled life. At the end of life, there's not going to be a grand prize for the person who ate the most broccoli, or the person who had the most nutrient-dense food, or the person with the best omega-6 versus omega-6 is to 3 ratio. And there's not going to be a grand prize for the person who ran the most marathons, or the person with the best HDL. No. What is going to happen is that I don't know if anybody, I would like to see in the, if we don't have a chat, it's a Q&A, but I'm sure, is anybody aware of Bronnie Ware, the 5 regrets of the dying? A hospice nurse in Australia who worked with hospice for a long time, and she did this documentary and wrote a wonderful book about the 5 regrets of the dying. Every time she worked with people who were close to their last days, she asked them, what was your major regret? And she documented it. And she documented thousands and thousands of people, and she put this together. Yes, more time. Yes, 5 regrets of the dying. Yes. So, and I highly encourage you guys to go find it. It's a little memoir. It will not take you long to read. Once you read it, it helps you readjust your life, readjust your practice to be able to merge those. I talk a lot about intentional. Oh my gosh, Amy, thank you so much. I love that. So it helps you to put things into perspective, like whether you're taking a statin or you're not taking a statin, that's really not the end of the world. My goal as a community pharmacist, or my goal as an integrative pharmacist, is to help you, give you the tools that you're going to lead a life that is optimal in your definition of it. Because I say my goal is to help people with pharmacy care and pharmacy practice, to help them to lead an intentional life. And if I ask everybody, what is the definition? What is an intentional life? What does it mean to be intentionally living your life? It's a different answer for every different person, and as how many people are on this call, that's going to be how many different answers we're going to get if we ask people to go around and share on this call. But here's what's happening. I look at it in my own perspective is, if intentional living is up here where you want to be, where you have assigned it, where you envision your life to be most fulfilled at, then that's your fulfilled life right there. Intentional living are those steps that you take to get there. And as long as you're taking small, consistent steps in the direction of that life, if you're going the other direction, that is not intentional living. But if you're going this direction, which goes towards what you have in your mind as the fulfilled life, as the goal that you have in your life, the way you want to live your life, that is intentional living. And as we as healthcare providers, integrative pharmacists, physicians, nutritionists, and everybody who are helping people to use the tool of health. Because when your health suffers, everybody around you suffers. When your health suffers, your caregivers suffer, your friends suffer, your family suffers, your business suffers, your community suffers. But if we were able to erect that pillar of health to be optimal, it will be able to support all the other aspects, and then the intentional living will be able to come with more ease. So that's kind of that's the pillars on which I always say, please envision a table with 4 legs. When you envision that table, the first leg is nutrition. Hippocrates says, let food be thy medicine, let medicine be thy food. I can give you all the metformin I want to give you. I can give you, the United States is 4.2%, 4.2, 4.6% of the world's population, right? And we consume over 60% of the world's prescription pain medication as a country. Just think about that for a moment. We're less than 5% of the world's population, but we consume over 60% of the prescription pain medication supply of the world. You would think that with that consumption, I don't know if it's greed or something, but you would think that with that consumption, we will be optimally healthy. We will not have any pain, but it's the reverse. In 1960, it was 1 in 100 people that were diagnosed type 2 diabetic in the US. Fast forward to 2000, 2001, there are about 1:10 out of every 1:10 people type 2 diabetic. Just think about that. We're trending the wrong direction, despite the fact that we have all the metformin, all the insulin, and now all the GLP-1s. Right now, about statistics as of last year, about 12% of the US population are on GLP-1s. So GLP-1s are 12% of prescriptions that are GLP-1s are 12% of the prescriptions that are sent out in a community pharmacy. So very soon we have almost everybody and their aunt and their mother and their sister and their father and uncle on a GLP-1. So it's not the prescriptions that actually give us health. So there's more to health than prescriptions. That's really where I'm going with all of this. And I just say that is what helped me to found Power Pharmacy and to be able to practice the way that I have it in my mind. You should see it in my mind. It's very beautiful. And I'm sure that you guys connect with me because I love talking to people who have similar point of view and similar practices, which is very refreshing. Let me see if I can. I'm gonna put away the questions so I won't see the questions, but I will look at them. Amy, and just if you can help me with the questions as we go. So my goal is to just talk a little bit. I kind of designed it like just what is the role of preventive medicine? I don't want to belabor these points because this is what we're already doing at our practice, but I want to highlight what I do at my practice may be beneficial or maybe inspirational to somebody on the webinar today. And I have highlighted, my goal is to have a pharmacy which is unlike any other. Patients come in and we test their nutrients, we test their biomarkers, we work together. And I tell my clients every time I go, if you see a healthcare provider who tells you that they can do it all, run 180 degrees the other direction. Once you see a healthcare provider who says, come, I know it all, I got it all, everybody else, I'm the one who knows it. But I say, I practice within my scope. I'm a pharmacist. If I measure the certain biomarkers that I could measure, my goal is to educate. As a pharmacist or as any healthcare provider, I always encourage healthcare providers as your work is 50-50. 50% of your work is educating patients. The other 50% of your work is giving them those tools that they help. So I will tell you what diabetes type 2 means, what insulin resistance actually means when I measure your insulin levels. What is the difference between your fasting blood glucose, your A1C, and your insulin levels? Explain that to you in very plain English in such a way that my mother can understand. That's 50% of my job has been done. So when you're taking your metformin, you know what that metformin is doing for you. And in addition to that metformin, what else in non-pharmacologic options that I can give you to optimize your blood sugar control? So I'm not against metformin. Some people can come and say, I don't want to take metformin, but then I have tools for you. There are things that you can do, there are things that you cannot do, and things that you can add to that metformin or do on their own to control your blood sugar and to control those insulin spikes. So if you come in today and my goal, I'm looking at patients, think of something like a statin. Somebody gets us, or we stick with the metformin even. I give you a metformin today and I'm like, well, take the metformin, take it with food, it could be upsetting to your stomach and then we're done. That's what you'll get if you go to a regular CVS or regular Walgreens. But if you come to a pharmacy that is taking one step further, I'm going to tell you, hey, I will not take a metformin without starting a B complex. B complex because metformin has been documented to deplete B vitamins. I would measure your B12 levels. I would make sure that I'm replenishing with a B complex. They work together, they work in synergy. But here's what I'm going to tell you one step even further. 5-10 years down the line, most of my type 2 diabetics are diagnosed with diabetic neuropathy. We could just sit and say, oh, well, it's a natural cause of progression of the disease. You were going to end up with that and we'll get a prescription for Lyrica, for duloxetine or gabapentin. We'll take care of that diabetic neuropathy as it comes. Or we could start giving you a B12 or B complex, or maybe some alpha lipoic acid to take with your metformin, as we're also talking about nutrient-dense foods, including fiber and things like that, to be able to help you get better control and encouraging you to move so that way you can get better control of your blood sugar levels and then eventually get better control of that. So that's really the goal. And we do that testing and I'm identifying those and coaching the patients towards better outcomes. So it's not instead of, if only one thing you take from my talk today is not instead of, it's in addition to. So in addition to what we have a basket of tools that we share with our patients, and they're welcome to pick anything out of that basket and be able to use to optimize their health. And let's see here, the slide moving. Yes, it is. Go. So we have about 60 to 70% of our patients are taking supplements now. And so after COVID did us one, increase the awareness of patients to natural options, supplements and vitamins. And this is being left to social media influencers because pharmacists shy away, most healthcare providers shy away from talking about supplements. And Kim Kardashian and Jennifer Aniston and all the people are on Instagram and TikTok telling them, you should take this, you should take this, you should take that. So we need to step up to be able to recommend supplements and vitamins with confidence. The best way we can differentiate ourselves from the people who are talking about it on social media is by testing. So we're not just assuming that, oh, your hair is falling off, you could take collagen. You know what? I could test some biomarkers and align that with your hair loss and be able to make recommendations with more confidence and some evidence based on it. So we'll take an example. For say Michelle comes into the pharmacy and she's complaining of all the regular things, fatigue, brain fog. She's, and she is on some prescriptions and she's like, what should I take? Multivitamin, should I take a B complex? Should I take vitamin D? I've heard that iron is good. I've heard collagen is good. What should I take? Where do we start with this patient? Patients like Michelle are everywhere. This a little bit further. Patients like Michelle are spending tons of money on the internet, buying supplements from TikTok, from Instagram, from Amazon. And the US supplement market, as of last year, was 69 billion. And just COVID time and after COVID time, the growth is 8%. And it's only increasing. We can sit in the back or we can be part of this. We can lead this shift as we help our patients navigate this. Reason why I decided to talk about this today when Amy reached out and said, I would like to talk about direct-to-consumer labs. And I'm sure several of you have heard of Function Lab, Superpower, and all the labs that are doing direct-to-consumer testing. So they're advertising it on Facebook, on Instagram, and the patient clicks a link, pays, and then they go test every year, and they get like 22 pages or like 10 pages of data, detailed data, and they have no idea what to do with it. Sometimes they give, an AI-generated review and said, oh, these are some supplements that you should take. This is what this is. And then you should test again in 6 months, or you should test again in a year. All of it increase awareness for the patient. But I feel like the healthcare provider should be in that realm. The healthcare provider should be in there to be able to break down those scientific data. You cannot just isolate labs by themselves and then break down those labs and say, hey, you have to be able to talk to somebody who already knows the patient. What medications are they on? What are their history, comorbid factors, other guidelines, taking those into consideration. So, but I feel like patients deserve a lot more than that. And there's a line I put a little sticker in my pharmacy. We engraved it in wood, and it's up there at the pharmacy. It is, we're prioritizing connection over consumption. So it's not about selling supplements. It's not about buying all the stuff, buying all the health gadgets. We can have all the exercise subscriptions and everything. Connection is number one. Connection with your healthcare provider, connection with yourself, connection with the people that matter to you. So those positive social connections. We bring it back again and say, think about that table. I talked about envisioning a table with those pillars. That table has 4 legs: nutrition. The second leg is movement. I can sell you all the supplements I want to sell. You can come to the pharmacy and buy all the supplements. If you go home and don't get your butt off the couch and move, that's a complete waste of time, energy, and money. You got to move your body. We got to add this non-pharmacologic options. We got to layer them on top of the supplements. We got to connect with people and understand, let them understand why they have to move their body. Don't just tell them, go exercise. Why do you have to exercise? The third pillar is inner alignment, measuring those biomarkers that transform, that make, like you're measuring all the neurotransmitters, measuring your hormones, measuring other biomarkers and lab values that we can put together. And then the last pillar, which if we do the first three well and ignore the last, will still not be at optimal health, is positive social connections. That last pillar, Harvard University did a study, one of the longest standing studies for longevity, and they said, the essence of life when for people to be able to live a long, fulfilled life, the quality of their relationships was the most outstanding factor. So if we have to pay something, you would think that cardiovascular disease will be up there. In my mind, cardiovascular disease should be really up there because cardiovascular disease kills more people than all cancers put together. So when you come, I always prioritize cardiovascular disease, cardiovascular risk management, but then loneliness, the avoidance of positive social connections is right there above cardiovascular disease. So we need to be able to prioritize that connection, talking with people, spending time together, talking about things that matter to us. So it's not just the lab. So we can do all the labs we want. We can get AI generated results, but we need a human. We need connection. We need that person to be able to explain those things to us. So, and we surveyed about 2,000, a little bit over 2,000 providers. And at my pharmacy, we had a lot of patients who come in with results from another lab or results that I did these results and these are the results from my wellness visit. These are results. Can you help me interpret this or can you help me? And that's a lot of people just looking for more answers. I said, nobody wants to jeopardize their health. People want to lead a fulfilled life and people want to help themselves as best as possible. So people are coming in like, this is just putting it all together. Like Michelle, think of Michelle. Should she get a multivitamin? Should she get a B complex? Should she get iron? And should she get the one that her girlfriend recommended at home because she said, oh, she's been taking this all through and she has never had COVID. This is a good immune supplement. And she's taking that and she has Eliquis that she's picking up at the pharmacy or Plavix, but that stuff has echinacea and astragalus and that's, and she would never come to the pharmacy and show me that stuff. The bottle is at home and she gets it from her girlfriend at Bible study. And that's kind of how it is. I have to dig to be able to find this out. So we do a comprehensive health review at the pharmacy where we say, you're not welcome to the pharmacy unless you bring your whole bag. So I want you to put a bag in your supplement or medication cabinet and put everything in it and bring to the pharmacy so I can see the back of the bottle. And we take a look at those and say, you got this from this pharmacy, you got this from Amazon, you got this from TikTok. Let's put it all together and see, do these go well with your prescriptions? So that's a comprehensive health review that we offer at the pharmacy. And which one should you and should you not be taking? When should you separate them? And basic things like that. She could easily be taking something that's for energy and taking it at night and then coming to ask for magnesium for bedtime for sleep. So we do measure values as well. And able to, and we just don't measure like the basic vitamin D or vitamin B12. We measure Lp(a). Less than 2% of the United States know their Lp(a) value, have measured that. And I'm excited that the new cholesterol guidelines are, mentioning this and, bringing attention to Lp(a). And I usually explain to patients, I go, think about this. Did you know, I asked them one question is I said, did you know what percent of people who have a cardiovascular event and have normal cholesterol levels? Does anybody know that answer? What percent of people have a cardiovascular event with normal cholesterol levels? Can we take a guess? Yes, Amy. Yes. Almost 75% of people that have a cardiovascular event have normal cholesterol levels. Just think about it that way. Like we all have, you've gone to the doctor, you've gone your annual wellness visit. Every year you're there at your annual wellness visit. They measure all your lipid panel, get everything, HDL, triglycerides, and everything is measured. It's looking fine. Oh my gosh, no, it's not looking fine. Emla, let's put you on a statin. Let's get me on Lipitor. I start taking it, and then my LDL levels come within range or they're not within range. Let's increase the strength, or maybe I got some muscle pain on there. Let's get you some, let's do, change it to simvastatin. Let's see how we are going to do with this. And we finally get my LDL levels within the range, less than 100. Yay, we're good. We're doing fantastic. Good, Emla, you can go home, take Lipitor for the rest of your life. But 75% of people who are admitted into the hospital with a cardiovascular event, their LDL levels are within goal, within normal, within the guidelines, less than 100. Think about that. What is happening? What's all this? This is why we measure the Lp(a) to increase that awareness, that education. I talk about 50% is just the awareness, just bring their awareness to it. I say envision your cardiovascular risk like a full circle. Split that circle into two. One side is your lipid panel, your HDL, LDL, triglycerides, the ratios that there is. But then the other side are the things that we've not talked about. The other side is what we're going to talk about today. Your Lp(a), genetic predisposition. About 90% of this, thank your parents for it. Thank your grandparents for it. So you have that gene. It's like a LDL with a little tail. That's what makes it. I just explained to patients in a way that, think about it, if your cholesterol is normal, just think about it that it kind of makes your cholesterol more sticky, and it just gives you a higher chance of having a blood clot and having a cardiovascular event in a very barest minimum levels. 1 in 5 people do have that gene. We're walking around. And by the time you celebrate your 6th birthday, that Lp(a) value is already what it's going to be for most of your adult life. So it's something that we should be aware of. And once we know this, we don't have medications to target Lp(a) yet. There are 3 medications in clinical trials right now. Surely by the end of this year, they'll be here and available. But right now, there are supplements that we can use to help, bring down those Lp(a) values. And we can hold the other values, the other aspects of your cardiovascular risk to higher standards. So we can hold your LDL to higher standards. We can make sure there are other things that we can tweak, but it's good to know this just so that you are aware. Apolipoprotein B, similar story. I would rather know my ApoB than to know my LDL if you were taking it from that perspective, because these are the things that are accounting for that 75%. C-reactive protein, high sensitivity C-reactive protein. It's not a specific marker. It's not the only marker of inflammation, but it's right up there, Once you see that high, red flag, questions, what's going on? Can we reduce that? What can we do to help this person's cardiovascular profile? And these are the things that when I measure, if you stop by the pharmacy and I measure these things and your Lp(a), I had a guy whose Lp(a) was in the 400s. I go, here's what's going to happen. Before we continue talking about anything, I need you to stop. I need you to reach out to your primary care provider and need them to refer you to a cardiologist, like right now. Like this had to have happened yesterday. So, and he goes, yeah, I'm here because my brother had a heart attack at 34. And I'm like, And 2 months later, we measured the brother's Lp(a), 300 and something. So we said, next step, calcium score test. You need to get calcium score. You need to get your soft plaque measure. You need to get to a cardiologist ASAP, so that we can be able to see and make sure that we're limiting all this, we're looking at all the 5 aspects of metabolic syndrome, waist circumference, all the things, HDL, we're looking at everything. We're not just isolating your lipid panel and looking at it and saying, go home, take a statin, So, and again, we're not against the statin. We're looking at all the opportunities. What can we do in addition to, not instead of, and educating our people. So, let me push this down a little bit. My questions keep coming back down here. Oh no, this is not what I want to do. Yeah. Nope. My apologies. Okay. There we go. That's much better. My apologies. So we identify this by talking with the patient. We offer the appropriate tests. We place an order, we review the results, as opposed to just giving the patient, you're in the yellow, you're in the green, you're in the red, basic things, they're like, oh, do you know your vitamin D levels? I'm like, if you're a Buckeye fan, I mean, I'm not going to talk to the person who said go blue in the chat because they're dismissed. If you're a Buckeye, I mean, even let's just include the blue people. Let's just include them. If you live above the 37 parallel, whether you're a Buckeye fan or you're a whatever fan, the chances are very high that you're low in vitamin D. And I put it there. In order to be my friend, your vitamin D levels have to be higher than 70. But guess what? If you measure your vitamin D, any of the tests, the range is 30 to 100. That's a very big range. That's like sending my daughter to school and saying, hey, Mala, go to school, get anywhere from a 31 to 100. I'm fine with that. No, this African mom is not fine with that. Very high standards over here. You're going to have at least a 70. So that 31 of your vitamin D level is not going to protect you from a cardiovascular event. That 31 is not going to prevent osteoporosis. We're not going to wait until sit and fold our arms like be like, oh, 31 is fine. You're in the green. Go home. And then when you turn 65, we're like, oh, bone density scan. Thank you, Emla, for turning 65. Let's do your 65 wellness visit. You need your bone density scan. Oh my gosh, you have osteoporosis or you have osteopenia. Let's start you on Fosamax. What happened? It's been a while. You could have started me on vitamin D and calcium long time ago. And then now you give me vitamin D and calcium when I'm 65. We could start these things a little earlier, and we could educate so that we're not just holding people to vitamin D at 31. We're optimizing it for women. 80% of osteoporosis patients are women. And we just wait until they turn 65, and then we give them Fosamax and say, hey, go your way. Take it, with a glass of water, stay upright for 30 minutes. You just tell all the people all the things, but what happened for the past 10, 20, 30 years that we could be helping this patient to prevent osteoporosis? 1 in 2 women will have a broken bone from osteoporosis after the age 50. 1 in 2 women will have an osteoporotic fracture after age 50. 50. But we wait and do the testing, the bone density testing at 65, because that's what the guidelines say. So the goal is to encourage us to screen all these things and educate patients. Nobody wants that broken bone. I don't want to be the one with the broken bone. I'm going to take my vitamin D. I'm going to take my calcium. I'm going to do all the things. I'm going to do strength training to be able to help myself so that I'm not that other woman who has the broken bone, osteoporotic fracture. Sorry. So what we do is we have like custom panels that we do for patients, and we just I've built them, and so that they come into the pharmacy, they can pay. We have a QR code in the pharmacy, and then they answer this survey. They have high blood pressure, cholesterol, and what they want to do for their lives, and just why they're interested in the test and things like that. I give them a baseline assessment, and then when the results come in, we interpret the results, go through it, and they have it on their phone, and they have it still in the green, red, yellow range. But then we sit down and talk with the patients about this, and we explain these big words to them. What the hell is apolipoprotein B? What is homocysteine? What is HDL cholesterol? What are these things? What does this mean to you? And how can you not only take medications to help with this, but what else can you do to improve, those pillars: nutrition, movement, inner alignment, positive social connections, those 4 legs of the table? Are we making decisions today that are strengthening those 4 legs of that table? That's intentional living in my books. If I'm making any decision, I use that as a yardstick. If I'm making a decision today, is it improving one of my pillars, or is it shortening one of the legs of my table? If it's shortening one of the legs, that table is going to be wobbly. And I don't want my table to be wobbly. I want my table to be balanced, all 4 legs solid. And then the platform of the table, the surface, now you could say prescription, now you could say supplements, but how do we know what prescriptions to give or what supplements to give if we're not testing? So this is what I offer at the pharmacy. And, I do the HSA, FSA eligible, and I just do these biomarkers, sit down with the patients for like 30 minutes and go through these biomarkers, explaining to them. And then they make the option, they can buy supplements, or we can compound hormones for hormone therapy for them. And we have an OBGYN at the pharmacy that will sit down with them, and she will go through their hormones and determine what supplements they should, what type of hormone replacement therapy, if they're even a candidate for hormone replacement therapy. And she will do that hormone conversation with them. But then all my pharmacists are trained to go through these lab values with them, and then be able to make recommendations with that. We're making recommendations with confidence, and then make guidance to the patient so that way. So now if Michelle were to, instead of just picking, hey, multivitamin or hey, ferritin, well, how will we know? She could be complaining of her hair, and her problem is that like I explained, I put it in like very basic language. I'm like, this is what's happening. If you've been taking, she goes, if you've been taking collagen and biotin or Nutrafol or whatever you've been taking for the past 5 months and your hair has not been growing, there could be something else wrong. Has your ferritin ever been checked? Oh, I don't know, but can I buy some iron? I'm like, no, I don't sell iron to anybody if I don't know your ferritin levels. I want to see your ferritin levels, then I'll determine if you should get iron. So because that's a possibility, your ferritin levels could be low. And if your ferritin levels are significantly low, as they are in most people, guess what? Your body's not prioritizing the ferritin. Is like, think about it like, transport your hemoglobin, transporting that oxygen to the vital organs. Your body is going to be like, it's incredibly smart. Ferritin is low. You know what? Let's prioritize sending oxygen to working with the vital organs. Let's send oxygen. Let's send nutrients to the heart, to the brain, to the kidneys, all the vital organs. Let's forget about the hair. And that's why your hair is falling, because your ferritin is low. So that's one of the reasons too. If your hair is falling, your body is prioritizing vital organs and being like, I just need to keep her alive. I don't care about the hair. She could be alive and bald. We're fine. So, but if you increase your ferritin levels, you soon start seeing your hair, the falling hair kind of starts growing back. Your strands start getting thicker. So very basic things like that, which we could add to our patients, and this increases loyalty, this increases retention, and it generates revenue for the pharmacy. It is win-win-win. The patients feel better, they refer more people, and we feel incredibly fulfilled that we have the opportunity to use the clinical knowledge, because one day we're all going to die, and we want to not keep all this knowledge we went through medical school, pharmacy school, nursing school, and keep it all in our brains behind a computer. We want to get out there, help the patients, talk about things like this, and help the patients and help ourselves to help our business. So the goal is really to be very proactive with our patients, enter those discussions with them. And the patients are already there. They're craving it. They're on TikTok every day looking at all the influencers, telling them what supplements to get. Oh, everybody should be taking creatine. And then they bought one already on TikTok, and then they come with it to the pharmacy. Is this good creatine? Is this the one that I should be taking? I hear everybody should be taking protein. Oh my goodness, and they're like, oh, we should all quit our jobs to be consuming enough protein. So it's better. So this is what we do at the pharmacy. And I just thought I'd share that with you guys today. And a little bit, I love to talk a lot more, but I prefer to leave about 15 minutes for questions. I don't know, so that way, but I love to connect with people who aren't here. 15 minutes, and my phone number, I share my phone number in the chat as well, and my email. And there's nothing more favorable for me than to connect with other healthcare providers. It makes me so happy to be able to see and spend time with other healthcare providers who think similarly. It's very refreshing. I talked with Amy for the first time on the phone, and I got off the phone, felt like I had talked to my sister. So, and that made me have a good day at work. And so I love it. I can tell you guys how much I love it. I'm going to put this chat up here. No, not that big.
You want to? I can read the questions too if it's easier.
Please, can you?
Great.
Let me.
So one of the
Yes.
first questions was just kind of asking a little bit more about the tests you commonly do. I know you talked about LP(a), high sensitivity C-reactive protein, and ApoB. Are there any other tests? I know you showed kind of the Journeys panels, but any others that, including vitamin D and ferritin, any other favorites you have that you wanted to share?
Oh my gosh, how much time do we have? So maybe I should am I still sharing my screen? I think I am.
Yes.
Dr. Tubo, you actually have more time than you realize. We don't have to stop at 8. We can go as late as 8:30. So if you have more to say, please do.
I love you, my friend. Thank you. All right. So let me just go back to that slide one more time. So if you go on my website on Power Pharmacy and click on services and click on journeys, you'll be able to see, if you click on these 88 biomarkers, you will see the bundle. These are just bundles that I've created because I just felt like it's nice to create the bundle so it's easier. And I direct everybody to the medium one, to the middle one. First of all, it's a business reason. If you, from business standpoint, people will always buy the medium based price than the upper one or the lower one. But I made the medium one the most clinically savvy for me because of the cardiovascular risk that we as a nation face. And as women, we face that too. So with that one, we do an omega check, which also does your omega-6 to omega-3 ratios, arachidonic acid levels, and your full panel, EPA, DHA, DPA, we test all of that as well. And then I mentioned C-reactive protein, vitamin D, B12, magnesium, and the full lipid panel and the full ion studies. And what else we measure in there? So, but it's a ton. And but that's and then I tell people, if you're concerned about hormones, then we add now DHEA, testosterone, estradiol, cortisol, and things like that. We add that for the comprehensive longevity with hormones, and then TSH, T3, T4 in that big one. But the middle one, yes. So it's I direct people towards the middle one. But if you're short on money and you cannot spend $389, we do a core wellness, and the core wellness has just the basic things, just a few tests, which I feel like a foundational. If somebody's like, what supplement should I take? I don't really have any disease states or anything, but I usually try to push people more towards that cardiovascular one. And that's really my goal, because if we could do anything and prevent one cardiovascular event in one family, we've done a wonderful job. And I believe that this $389 is like worth it. Money we can somewhere, it's going to be so much fun, but I think it's much more actually do that test. And then I'm like, okay, my sister or my friend, you have a high ApoB, so we're going to have to be more stringent on these things. No smoking for you, no alcohol for you. We're going to try to limit it as much as possible. And the goal is, we always think of 80-20 Pareto principle, right? So it's economy. We borrow it in pharmacy. We borrow it in healthcare. 80% of the time, we're very intentional about what we're putting on our plate. But 20% of the time, we can go out for ice cream. We can go have a drink. We can relax 20% of the time. But 80% of the time, majority of the time, if we are consistently taking steps towards that intentional living, towards that goal, our health will be balanced by 80% of the time. 80% of the week or 80% of the month, we're working out, we're lifting weights, we're going to build muscle. Versus 20% of the time, we can relax, we can watch a movie and have fun. So life is supposed to be a life well lived, so that at the end of life, we'll not be on our deathbed and still be trending towards Bronnie Ware's 5 regrets. So my goal is not to be on that 5 regret list. So anything I can do to not be on that list, so by the time of my deathbed, I'll be like, peace, y'all. That was a life well lived. So yeah. I don't know if I answered that question, but the biomarkers are, my favorite biomarkers are those ones: ferritin, Lp(a), homocysteine. Oh, homocysteine. I didn't talk about homocysteine. Cardiovascular risk marker. And guidelines say homocysteine should be less than 13. I hold myself to very stringent rules, like more, no, guidelines are 13, but EMLA rules are 10. In order for me and you to be friends, your homocysteine should be less than 10, because I don't have time to come visit you at an early onset dementia place or cardiovascular marker, and also a risk for early cognitive decline. So we want the homocysteine levels to be as low as possible. If it's high, we give you a methylation synergy, something that, will be able to, the B vitamins are responsible for converting that homocysteine and recirculating it. So we're not playing that game. So, and we also test your ApoE genes. If you're interested in knowing, we also test your MTHFR and things like that. Yeah. Thank you for that question.
Great answer. Okay. And then there was a question, I know you mentioned during your talk that there were 3 supplements you recommend for Lp(a). They'd like to hear what those supplements are.
Yes, Lp(a). Yeah, I don't think you guys want to hear one of them. A lot of physicians don't like giving niacin to their patients. So niacin is one of the supplements that does reduce Lp(a), but it comes with side effects. So weigh your situation very carefully. Listen to your patient, look at them, measure their kidney. So in this metabolic, in the core wellness, even we measure your liver function test, where your AST or ALT, and we measure your GGT, and we look at your liver function test. And if you really really low risk, we could put you on a niacin, but being very cautious and checking on you every month. But that's one of them. And then the other one is CoQ10. I put them on a high dose CoQ10. I put them on CoQ10 300 milligrams. Can do no harm. CoQ10 is the multivitamin if you have cardiovascular risk in your family. If you give me CoQ10 and a multivitamin and say, I can only have one, guess what? Which one I'm picking? CoQ10. You're going to get better benefits from a CoQ10 than from a general multivitamin. If you're following those pillars and putting nutrient-dense food on your plate, you're going to get more benefit from a CoQ10. And we give them CoQ10. We also give them berberine. Berberine can help with those Lp(a) levels, because berberine overall, the metabolic syndrome, we have berberine has very strong. It will help reduce all those other risks, so that the risk from the Lpa is low. We've reduced people's Lpa by up to 40 points by putting them on one or two of these supplements based on their comorbid factors and things like that. So those are some of the things that we do. And this, and you look at risk all around, and it's not a one size fits all again. It's just, and I do have a course that I have on my website that I teach other healthcare providers how to interpret labs, like advanced biomarkers and things like that. So, and how to interpret this in such a way that patients can understand, and what supplements to give for which ones in addition to, and things like that. So that's what I do. So.
And then
Yes, dear.
they asked if you could please provide resources, or maybe like your favorite reference for drug supplement or nutrient depletion drug interaction checkers.
So I use I use Fullscript a lot. So there is a Fullscript one. There's one in Fullscript, and that has that one is drug nutrient. That one is drug nutrients and drug herbals that I have in there. And I also use database of just natural comprehensive medicine database. Not very strong, but Fullscript has one which is called Fullscript Assist, which I help build. So that's my favorite. Yeah. So yes. So that's my favorite one to use. Yeah.
They also asked, I've noticed a new AI tool called Journeys that helps providers interpret functional medicine labs through Rupa or Fullscript. And they wondered what your thoughts are on this.
I love it, because Journeys this is basically what I'm using. You customize it, because it's not a one size fit all, like the superpower and the function. You can customize it too. So this is a function of, this is Journeys, what I'm using right here. So, and full disclosure, see, this is not CE, right? This is not CE. So full disclosure, I help to build Journeys. So I help Fullscript to build Journeys. So this is and this is so that way to give providers the power to be able to build this. You can build custom panels. You can be like, Emma, I don't like your panels. I can build mine. You can build a hormone panel. You can build Dr. Amy panel. You can build whatever panel you like. You can build a family panel, and then pick out the labs you like, add an interpretation fee on there, and put it on there. And you will be able to do that. It's generated. It's AI. AI will help you put all of them together. And then you go in and edit it, and then you sit down with the patient, and then you interpret the labs as with that patient connection. So you get all the values, layer them with the AI generated interpretation, and then you now talk to the patient. Yeah.
And then with your favorite supplement, the CoQ10, for cardiovascular disease, they were wondering if you specifically recommend the ubiquinol, or if you tell patients any CoQ10, or which is your preferred?
It again, so it really depends on the patient. So if you're a younger patient, let me say, what's my cutoff? Let's say 40. Okay. So let's say you're 40 and below, and your body can actively metabolize ubiquinone, go for the cheaper option, right? But if you're 40 and above, right, your levels of CoQ10 are already significantly declining, you have a cardiovascular event already, or you are already on a statin, we're going ubiquinol. So it's really different, based on the patient. So, and I have both at the pharmacy. So, and you know that one is cheaper than the other. So, but it really depends on your risk. And if you have high LP(a), sorry, you just bought the active one for the rest of your life. So, and that's basically it. And all my patients that have high LP(a), I'm making them aware that, hey, your next step is to have a calcium score on board. You need to go get that done. You need to assess your risk, and go one step further. And I check in on them, make sure that you've seen a cardiologist for this. And then when the 3 medications that are on, I think they're on phase 3 clinical trials right now, when they come out, I'll be doing podcasts. I do have a podcast. It's Intentional Living with Emla. It's available on Apple Podcasts, Spotify, and YouTube. If you haven't noticed that I like to talk, I try to explain these things in a way that people can understand, and I bring guests on there. And if you'd like to be a guest on my podcast, I would welcome you. My goal is to get integrative providers, functional health providers, and to be able to get them out to the public. So people hear you guys who have the clinical expertise rather than hearing from the influencers. You guys have the degrees, you guys have the knowledge, you guys have the evidence-based practice and background. So I want more people to hear from you guys. So I'll share a link of my podcast so Amy can share with you guys. But the goal is to, I don't know, did I answer that question?
Oh, that's great. And I love your podcast. I recently listened to a few episodes, and I think it's great. So I
Thank you.
are a couple more questions, and
Yes.
I won't take up too much of your time as well. But there were a few questions about vitamin D and
Yes.
osteoporosis and K2.
Let's talk about that.
Yeah, and they were kind of asking about getting some of the vitamin D testing covered by insurance. It seems like in your practice you're not billing insurance for testing. But if you want to speak to that a little bit, and then why levels are low, is there any kind of connection with underlying low iron deficiency or other deficiencies, and then K2 along with the vitamin D?
Yes. So first of all, I start with geography, vitamin D. Like I said, if you're a Buckeye fan, or you live in Ohio or anywhere above the 37th parallel, I think it's from San Francisco all the way to like North Carolina. If you live on that line or above, you are deficient in vitamin D, most especially because we don't have a lot of foods that are high in vitamin D, and the fortified foods come fortified with sugar as well. So, so my goal is to be able to measure your vitamin D levels. And I usually do, because I do all this bundle, I don't usually do insurance. These are HSA, FSA eligible. So that encourages patients to test, especially when they have dollars left over on their HSA and FSA card. They usually would test with that. So we've really not had patients, declining because of the cost. And to see patients who are interested in these values, people are genuinely craving this data, this information. So when I tell people, I say vitamin D is one of those things which, cuts across all the different health. It will boost your immune system. It will help you with your cardiovascular risk. If I were to wait as a pharmacist, even before I opened my independent pharmacy, what I would fill prescriptions for 50,000 units. If somebody has a cardiovascular event, usually when they're bringing in a prescription for Plavix or for Eliquis or things like that, they're also bringing in a prescription for vitamin D, 50,000 to take once a week. Why do we wait until the person has a cardiovascular event? Then we give them vitamin D 50,000 to take once a week. What we could have done is we could have given them maybe 5,000 to take daily to keep them up there, because we told them that 31 was okay because the range is 30 to 100. That's a pretty big range. I could be 31 and then you are 85. If you and I are twins, Amy, right? And my vitamin D is 31 and your vitamin D is 85. And we live 67 until 70. If two of us fall, who do you think is going to have the higher risk of having a fracture? Definitely me, because the way I look at it is I tell people it's very easy. Think of calcium coming into your body from your food or from your supplements. The calcium can go to two places. Calcium can go to your bones. That is your strong tissue. That's where we want calcium to be. Bones and teeth. That's where we want calcium to be. Strengthen that bone so that way we have lower risk for osteopenia and osteoporosis. Calcium can also trickle into the soft tissue. That's your arteries. That's your kidneys. We don't want calcium in there. Calcium in the arteries, your arteries are looking like that, the nice little lumen. When calcium goes there, it calcifies it. It's not as nice and smooth as that. Undulations and all the things, plus cholesterol, plus all the other risk factors, plus Lp(a) and all that stuff. Your lumen is going to be smaller because of that calcification. That's why I want to measure that calcium score. We don't want calcium in the soft tissue. Calcium deposits on the kidney causes kidney stones. That's why you're seeing an uptick in kidney stones, because everybody on Instagram and TikTok is telling you, go get vitamin D, buy vitamin D, buy vitamin D, buy vitamin D. But they're taking that vitamin D, it's enhancing the absorption of calcium, but that calcium is going to the bones, some is going to the soft tissue. But vitamin D3 with K2 is blocking the vitamin D, blocking the calcium from going to the soft tissue, so that way we're having more calcium going to the hard tissue where we want it to be, and enhance that and make sure that our osteoblasts and osteoclasts are in right balance, and we're preventing osteoporosis. And then, so I usually give vitamin D maybe 5,000 units with like 45 micrograms of K2 for daily uptake, just to maintain your vitamin D levels for the average person. But then for anybody who has been diagnosed with osteopenia, or you have a cardiovascular risk, or you come with, that reminds me, for people with high Lp(a), I always give them a K2 at least 180 microgram, because high doses of K2 have been studied to actually reverse calcification. So that way, the little calcium that was depositing in your artery, if you're taking a higher dose of K2, and that can help reverse calcification of those arteries. So I will give them the same vitamin D, 5,000 units, but then with higher dose of K2 that will increase the chance of that calcium leaving the arteries. So that's one of the things that I do. And then we don't forget, cofactors like magnesium, vitamin C, all these other things in addition to. So we measure, other and then I give them, N-acetylcysteine. Just people who are more prone, if you have a high Lp(a), we're looking at your whole system. We're looking at everything we can do to reduce your cardiovascular risk. We're making sure that I'm connecting you with my dietitian so that she can make sure that your lifestyle encourages you to be able to put nutrient-dense foods on your plate. So that's what's the vitamin D. So we'll do calcium. We have all the options, citrate, carbonates, making sure that it's buffered, chelated salt forms. That way it's not upsetting to the stomach. And give them capsules, and we give them chewable calcium, or, depending on their preference. And then the vitamin D, just to make sure that we are covering our bases from a preventive standpoint, and the best we can do from a supplement standpoint.
There was a couple of questions about which actual labs do you use, Quest or LabCorp?
I partner with Quest. So with this, and this is something which any healthcare provider can do. Any healthcare provider can put together these panels, and that's something that I'm willing to help anybody. It costs you $0, costs me $0. And anybody who is wants to implement this at their practice, I can help you set it up. And you can reach out to me, send me an email, give me a call. I would love to help you set this up. I use Quest. Quest is all around, and it costs them nothing because the lab fee is embedded into these prices. And there's actually, the lab prices are actually way lower than these. These prices you see here include the profit margin for the provider already. So with the journeys, the labs are already there significantly lower than this. So the prices you see here include profit for the provider as well. So that way you're helping your patients, your practice is benefiting, and then your patients are going out with valuable information in the long run. So generally, so I'd love to help people set this up if it sounds appealing and exciting for the patients.
Good. And then there was a question about nattokinase. Ever use that or recommend it, or what are your thoughts as far as arterial and endothelial tissue?
Yes, tomato kinase. So I love, if we can go in, and be like the Japanese, that would be a lot better for all of us, get it from the food, primarily food first all the time. But it's like an insurance policy. We cannot be safe all the time. So we'll prioritize our supplements there. Nattokinase will be right up there for people with LP little a for me, in my mind, So if you test your LP little a, we're going to put together your supplement list and look at the, oh yeah, somebody put that right. Yeah, so nattokinase will be up there. Not just people with LP little a, all around cardiovascular risk, So we're looking at it like, I am a healthcare provider. What can I give this patient to be able to help, improve their risk panel? If this patient were my brother, if this patient were my sister, what would I do to them to make sure that we're providing them with as many tools as possible? We take them on a walk. On a Saturday, we go out walking, we text around here. We're meeting at Antrim Park or we're meeting at Liberty Park down here, and we're going to walk. We're going to meet there at 8 o'clock. Anybody wants to come, feel free to join us. So sometimes 10 people show up, sometimes 5 people, sometimes 20 people show up, sometimes people show up with their dogs and their strollers with their babies. That's adding that pillar of movement in there, So whatever we can, and chances that I'm eating Japanese food that doesn't smell good, I'm not sure, but we can do some nattokinase for sure. Yes.
All right. Well, thank you so much. I put your email in the chat and I put a link to your podcast.
Yes.
Thank you so much for being with us tonight. This was great. We really appreciate your time and your expertise.
Yes, thank you, Dr. Tumo. Appreciate it very much.
Oh, thank you. I love being in spaces like this. One part of me with the webinar is that I'm not too sure how much I love being on a webinar, looking at my slides and talking to myself. I want to see people's faces. I want to talk with people and answer questions and get feedback and learn from other people. So my email is in the chat. I saw that Dr. Amy put it in the chat. So send me an email, call me. To me, this is the life that we want to live. This is what makes our practice fulfilling if we help each other and we hold each other on this journey of health for ourselves, and for every other person. And I also really want to tell people I have high LP little a, and that's part of the reasons why I'm so passionate about this. So I'm grateful to my parents for giving me that. But but now that's my passion, to educate everybody about it. So yeah.
Somebody had asked before about the
Yes.
recording, so I just put it in the chat, but I just want to repeat that the recording will be available to everybody who signed up for this talk. I mean, it's going to be eventually publicly available to everybody, but everybody who did register will get a notification from me when the recording is ready. So don't worry about that.
No, thank you. I'm really honored to be here. I'd love to help people to be able to do, because I think that people want to do stuff like this in their practice, and people want to be friends with people who are doing things like this already. And I only have one friendship condition. Your vitamin D levels has to be higher than 70.
I love that.
That's all. If your vitamin D levels are less than 70, we have issues. We'll have to rectify that before we can be friends. So
you have a lot of people in this country who you can't be friends with right now.
That's true. And I don't have a problem with that. I'll fix their vitamin D levels and then we'll be friends. So,
okay. Fair enough.
So, but I know everybody on this call and this webinar is going to join me to help fixing their patients' vitamin D levels so we can all be friends. Thank you for having me.
Yes, thank you.
Thank you so much. Thank you, Amy, for helming everything.
Yes.
Appreciate it.
All right. all. Have a good night. Bye.
Good night.
Thank you.